Hello from Berlin, and once again, welcome to the Quintessencial Thursdays. Today marks the 16th episode of our webinar series, and we are very happy to welcome 4 world-renowned experts in their field. Today, we're going to talk about the adjacent implants in the smile zone, the do's and don'ts. The moderator will be Professor Nitzan Bichacho, and we have the pleasure to welcome Dr. Paul, Dr. Manku, and Dr. Chu, who will share their expertise in the field of aesthetic dentistry, especially in implantology. So once again, I hope you enjoy the session. Be interactive, ask your questions, and be safe. See you soon. Please go ahead, Nitzan.
Hello, I'm Nitzan Bichacho, and I would like to say hello to everybody from sunny Tel Aviv. Today, it's a pleasure for me to moderate the session with 3 friends from different corners in the world. Snezhana Paul from Kirk, Croatia, Steve Chu from New York, USA, and Tidu Manku from Windsor, Great Britain. So my role today is just to set up the stage for my friends, and I would like just to pinpoint some problems that we encounter in modern implantology today. So when we look at such a situation, a single implant restoration, at the smile zone, we can see that even after 3 decades, the overall appearance is not so bad. And actually, what our patients are looking for is to have a nice smile. They don't really care if they have 1 implant or 2 adjacent implants. They would like that when they smile, nobody will notice that something artificial is there. So the question is, how can we manage such treatments to look inconspicuous to the human eye? So again, those days, 3 decades ago, we knew that we can get pretty stable tissue around the implant restoration, both the bone and the mucosa around it. But the problem, especially in central incisor implants, was always the distal papilla that was relatively short compared to the homological one on the other side, as we can see here. During the years, we learned different techniques in order to try and solve it. And as we can see here, a more recent case, after 6 years, the central implant has a pretty nice architecture of mucosa around it, including the distal papilla that is at the same level of the natural adjacent central incisor. And as we all know, one of the reasons when we have a single implant in between natural teeth to have this type of nice bony and mucosal architecture is the support of the adjacent natural teeth through their periodontium, through the Sharpie fibers, the support of the peak of bone between the natural tooth and the implant, and the support of the papilla that is actually mainly through the Sharpie fibers originating from the natural tooth cementum. We can start a situation like that. As you can see, implant restoration with very thin mucosa around it. The distal papilla is relatively short. And after a sequence of treatment, including connective tissue graft and replacing the whole prosthetic components, 4 years post-surgery, we can see on the right-hand side of the screen the result, which is much more stable for the long run and looks more naturally. And if we compare the starting point where the discrepancy between the two papillae, of the distal papillae of the central incisors was about 6 degrees, we can see that we almost level it throughout this type of procedures. We can also see that the bone around the head of the implant became a little bit more pronounced, especially at the distal part or mesial part, sorry, of the implant restoration. And this is again something that we know how to do, and my colleagues later on will elaborate on it. Even when we start with a difficult case like that, where there was a significant bone loss and the tooth had to be extracted, in a series of treatments, including surgery, orthodontics, another surgery, implant placement, and then correct manipulation prosthetically, we can end up with a nice result that the patient will like. So we are talking actually about harmony and even symmetry between the right and the left hand side. The most important thing is how can we actually maintain or can we recreate the peak of bones adjacent to the implant, and we will discuss it surely in the coming 1-2 hours. We would like that the peak of bone will be there in order to support the papilla. Problem is when we are talking about adjacent implants. Now, when we talk about adjacent implants, the inter-implant peak of bone is not supported by adjacent tooth. The inter-implant papilla is not supported by adjacent tooth. And we need to try and use different techniques in order to create or maintain the papilla if it was there before removing the teeth. When we talk about two central incisors, this is not much of a problem because even if the inter-implant papilla is shorter, because it is a single papilla, there is no other papilla to compare to, then the human eye will catch it as a symmetrical picture. So in such a situation where the two central incisors had to be removed, we can see that 2 years post-connection of the implant crowns, although the inter-implant papilla between the two central incisors is short, we started with a situation where the papilla was short, as you can see here. So we were not able to grow it more, but still the overall result looks pretty aesthetic and natural. And of course, again, the underlying bone has to be there in order to support the tissue, both buccally and interproximally. Problem is when we get into such a situation, when we have unilateral adjacent implants, like in this situation where we have a central and lateral incisor on the left-hand side. And as you can see, 21 years after treatment, the bone resorbed to the second threads of those old-fashioned implants, and the clinical situation is not so appealing. The inter-implant papilla is very short. I would say we cannot call it a papilla, it is a mini papilla. But still, this type of case is very, very dramatic when you come to challenge the practitioner in order to try and end up with better results. So we are not talking about situation like this one when the patient has very low upper lip line that covers the problem. We are talking about those situations where the patient actually reveals the tissue around those restorations. We know that there should be a minimum distance between the two implants of 3 millimeters. We know that the implant configuration might play a role in order to try and keep the inter-implant bone or peak of bone. We know that the prosthetic workflow has to do. We know that if we can maintain an existing nice configuration before removing the teeth by placing the implants immediately and even supporting the tissue immediately, this might have a role. But at the end of the day, this is always a very challenging situation because it is not obvious that this type of inter-implant bone will stay there and not flatten or even resorb throughout the years. So years ago, and this is an old case, we decided many times instead of placing implants in this type of missing two adjacent teeth, the central and lateral incisors, to support the tissue by two pontics. As you can see here, the provisional pontics that enable us to have a nice interpontic papilla, and then the result after 23 years, which is not bad. The papilla is still short, but it stays there. The harmony is obvious. And as you can see on the radiographs, those years I decided to retain the roots, trying maybe to support the tissue or the bone. Those years we had different strategies than we have today. And I believe that Snezhana will elaborate on trying to keep parts of the roots in order to support the tissue. Another similar situation, central and lateral incisor missing. Here, the defect was larger, and we always need to think what is the risk of our treatment, what is the starting point, the defect magnitude. These have to do with the treatment planning that we are going to choose from. And here, the patient couldn't go because of systemic problems through surgical augmentation. And we had to fill up the space, as you can see here, especially the papillae between the pontics and the adjacent abutments with some artificial pink, as you can see here. And again, this can end up with a pretty nice result when this type of restoration is functioning in the wet oral cavity, as you can see here. And at the end, when the patient is functioning, the aesthetic result is definitely acceptable. Same might go when we talk about multiple adjacent implants, and especially when we talk about unilateral problem. Here you can see that we had to pump the tissue both buccally and apically, and we did it again with some pink, as you can see here. And again, when we magnify, you might see the line between the artificial pink and the mucosa. But when the patient is functioning, this is what she reveals. And again, this artificial pink papillae might look nice. So we would like to find other solutions in order to end up with reasonable aesthetic results when we have to restore multiple adjacent implants, especially unilaterally. So I would like now to call to the screen my friend, Dr. Snezhana. No, let's start, you know what? Let's start with America. Steve, would you like maybe to start and set up the rules that we would like to understand and to respect when it comes to some aesthetic determinants in this type of situations? Show us what you believe is imperative to follow, and then we keep on with Snezhana and Titu. Steve, please.
Okay. Thank you so much, Nitzan, for doing such a wonderful job of really, sort of outlining, all the issues. And you covered it really quite well. And what was amazing is that you had really nice long-term follow-up. I don't have the follow-up that you have, but it's great to actually see, and you really condensed the information very, very well. So thank you for moderating this session. I think we'll have a great discussion afterwards. And it's nice to see you and having your new baby as well. So hopefully
Thanks.
It's nice
Steve,
to see
real quick,
Christian.
if you want to restart the presentation because there's a little fragment in the window, just, I think it's from the video, just close it one more time and open it up again. Just so we don't have a fragment in the window. See that window? Can you move that out of the way to the top right corner? There's something that is in the presentation.
Gee, I don't know.
You just start the presentation. It's just a fragment. Now it's gone. Perfect.
Perfect. Thank you, Christian. All right. So this Quintessencial Thursday, and what I really like about the topic that Christian had given us is really adjacent implants in the smile zone and the do's and don'ts. And I think that's really sort of a critical piece. And what would we do and when would we not do it? My charge is to really talk about managing post-extraction sockets. I know that Snezhana is going to talk about socket shield, and I know that Tito has some also very long-term follow-up. Tito has done a lot of this work previously, and he's published much on this topic as well. So I'm just going to be talking about post-extraction sockets. As a disclosure, this is a free webinar sponsored by Quintessence Publishing, but none of us are receiving any honorarium for the webinar. It's just giving back to the profession. I haven't altered any of my material, and I do have a financial interest in products I've developed, but I don't hold any shares in any company, commercial company. The question really, is there a problem? I think, again, Nitzan showed it very well. This is a patient that obviously has a lateral to lateral incisor implants, or as Nitzan elegantly showed, the central lateral dilemma, which I know is what Snezhana is going to really talk about. But these are big, big problems that patients come in with and how it affects their smile. So within the theme, I'd like to talk about some of the aesthetic determinants that I think are important. We'll talk a little bit about biology, and I think Nitzan covered that very, very well. And then we'll talk about some of the treatment considerations that we should consider when we're talking about post-extraction sockets and adjacent implants in the aesthetic zone. Let's talk about some of the smile determinants. There's basically 4 things that we really need to know, and I'll just sort of condense and summarize it. And I think in the smile, what's important, and a lot of people talk about having a low smile line, but the reality is that usually there's the papilla display in the smile. And I think that's something that we really need to pay attention to, because there's studies that were done by Dejan Miller and Thie and recently by our group in New York really talked about papilla display in over 800 patients if you combine both studies. And what we found is that the papilla shows in the smile roughly 87 to 100% of the time. 100% of the time on younger patients and about 87% of the time in older patients with a low smile line. So you may think that they may have a low smile line and they're an older patient, but the papilla still shows. And that's why it's such a problem that we have to deal with. The second issue is really what is the layperson's preference for the papilla showing in the smile. So if you looked at pink in the smile versus saying long proximal contacts or having white and no pink, or having black triangles, which would be the patient's preferred smile design? And obviously everybody would realize that the pink is what patients actually prefer in the smile. And what's very interesting is that long proximal contacts were not as favorable as to having pink. Obviously having no papilla was the worst. The third issue is really that a lot of my friends say, well, you know, they show cases and they show a gingival scallop. But the question is not that they have a scallop, but really how much of a scallop do they have? And Nitzan shows some beautiful cases of really having that beautiful scallop. And the reality is that in some studies that we also had done is that we looked at what we call a papilla proportion, or what was the length of the mesial and distal papilla relative to the gingival zenith position. We found that there was a range in papilla height from about 4 to 5 millimeters, but what we found, which was very consistent, was that the papilla height, whether mesial or distal papilla, was roughly 40% the length of the tooth from the gingival zenith to the height of the papilla. We also asked another question, which was there any difference in mesial versus distal papilla height? And the answer was no. There was no statistical difference. And that makes it easy. When you are looking at the papilla afterwards, then you want to make sure that the papilla is in a line that Nitzan had said. So there really is no difference. Now, the visual appearance is that the papilla, the distal papilla is more apical, but that has to do probably with the plane of occlusion. But all intents and purposes, they're equal in height. And the last would be the contact area, which is very important. Restorative dentists can control this very, very well. And it's very important to understand that the contact area that we can control defines the presence or the absence of the papilla. And when we have the contact area, it actually sits in the interdental caul, and then you'll have a buccal and lingual peak of papilla. And if you're doing an immediate, you want to preserve this and not destroy it. And obviously, if you have a delayed site, then maybe by reforming the contact properly, you'll have the reformation of the papilla. So the relationship of the contact area to the interproximal, the contact area and the gingival embrasure is very, very important. We need to respect the contact area, but have enough gingival embrasure to allow the papilla to actually reform. And that's very, very important. In regards to biologic determinants, well, you know, Nitzan said this very well. I'll just summarize it, is that the labial plate is thin. We all know all the studies that show that. Implants placed into extraction sockets do not alter the wound healing if the labial plate is very thin and you have a wide implant, you'll have bone remodeling and resorption. Implant position and diameter are critical. So if you notice that Nitzan showed narrow diameter implants or more narrow diameter implants, in the coronal, probably about 30 or 40% was parallel. And I think that's very, very important. We'll talk about implant design a little bit later. So implant position is critical. So you want to use smaller implants and you want to move it away from the labial plate. Internal socket grafting helps to minimize ridge collapse and improves aesthetic outcomes. And we need to have vascular bone all the way around the implant, both facially and interproximally. This has been well documented by Danny's Boozer's group that looked at 10-year follow-up, and he found that you need to have preferably about, I would say about 2 millimeters if possible, but a minimum of 1.5 millimeters around the implant, both facially and interproximally. And that's between implants, hence what Nitzan said, you need about 3 millimeters. And it's really all about biology. It's also about the horizontal component of biologic width, because again, with non-platform switched implants, it's about a 3 millimeter distance. With platform switching, you can cheat a little bit. Maybe it's closer to about 2, but I would still recommend that. I think 3 is still a good number. And therefore, the importance of using narrow diameter implants, I think, is extremely critical. Well, what are some of the treatment considerations that we would have to think about? Well, in regards to post-extraction socket implants, we want to have really the correct periodontal and gingival architecture to start. And I think that's very important to understand. that if you have the correct periodontal and gingival architecture, you want to be able to just maintain that. And that's one of the critical factors. So it's really about preservation of existing anatomy, and maybe the socket shield technique may help us in that regard. So again, Sanjana is going to discuss that. If you have excess tissue, say that you have excess facial and interproximal tissues because say the teeth are short and are super erupted, then that gives you excess real estate to really manipulate, which I find is quite helpful. And again, if you have a very flat gingival profile, say a papilla proportion anywhere from say 20 to 10%, then you have the ability to sculpt that tissue. And I think that's very, very important. The question in the Q&A section that may come up is that if you have short teeth and you use the socket shield technique, will you be able to push the tissue midfacially? Would the shield be in the way? And also interproximally. So this is something I think we need to discuss at the discussion part. The logistics in regards to this whole situation of post-extraction sockets is that we would obviously want to use narrow diameter implants, but they're not as effective in soft quality bone. And usually in the maxilla and the smile zone, the bone is usually, D3 or D4. So you usually have soft bone. Hence, I like using hybrid implants. Nitsan has the V3, we have Inverta that works quite well in soft bone. You want to graft all the way around the implant, not just facially, but interproximally, because we know that grafting will thicken the tissue. It can thicken the facial tissue as well as the interproximal tissue, so grafting is important. And again, that relationship between creating enough gingival embrasure and still maintaining the contact area with the provisional, because you're obviously doing a provisional in transition, must allow for the papilla to reform. And I'll talk about some of the situations of how to manage the provisional and where I fell short in certain instances that I was not able to retrieve the papilla. So it's very important that the prosthetics really does its job. Again, I'm not in favor of wide implants at the crest of bone because I think it burns the bone. You don't have enough gap distance, and hence you don't have enough labial plate thickness reformation. And as Nitsan said, you could get too close to the adjacent tooth and burn the papilla there. So I think it's very important to understand that wide implants I'm not really in favor of. I'm more in favor of hybrid implants, either the V3 or the Inverta implant, which I find works extremely well because then you're getting the benefit at the crest of a narrow diameter implant, but not sacrificing primary stability, so you can get primary stability with a wider diameter implant. This is something I recently wrote in one of the issues, special issue, and talks about hybrid implants. Again, the V3 or Inverta implant, two different systems, but basically the same or similar concepts. The V3 originally was for healed ridges, but I think it's also very good for extraction sockets. It has a parallel coronal portion with 3 flat sides, and the parallel coronal portion originally was only about 3 millimeters, and they've extended that, which I think is a great design change. And the coronal portion is parallel, so you don't have a wide flare top, and it has aggressive apical threads for primary stability. Inverta has some differences with it. The coronal part is parallel, but the coronal dimension is reduced diameter. And instead of 30%, it's almost 50% the length of the implant because it has a transition zone. And then it's only about half the implant length that you really need for stability. So again, it has aggressive apical threads, and you could have it either in a straight or uniaxial version versus a coax version, which I'll discuss. The original idea was just to take, wide diameter implants and just shrink the top and not have it as a liability in an extraction socket where you're really fighting for room at the crest. You're not using the whole implant anyhow. You can make the apical portion with more aggressive threads, and instead of it being, again, divergent and wider at the top, it will just be more convergent in shape. We have about 5 research-based articles published from 2018 to present time. And again, it's trying to give you the best of sort of both worlds, where you have aggressive threads at the apex of a wider implant and a more reduced coronal portion and even a coaxis version. And Dennis Tarnow, P.O. Osman, and Costa Nikolopoulos and Howie Gluckman really worked on the final design to make it all work together. Here's just some examples. This is a patient who had two central incisors. You can see they're fairly blown out sockets with these large apical lesions that are failing. She had this excess tissue. It's not a fistulous tract. It was just a fibroma. We had it biopsied later on in treatment. But the real key here is that if you have really compromised sockets, it would be nice to be able to do immediate therapy so you can try to maintain all this gingival architecture. And with these better implant hybrid designs, I really feel you can do these cases on a more consistent basis. Again, atraumatic tooth extraction really thoroughly debride the socket. That is so critical. We have these extended length-specific drills. They basically have an extender built into them. And what's nice about this coaxial type of concept is that you can go behind the lesion and drill toward the incisal edge. So you have the ability to drill behind the lesion and then place the implant. So the placement of the implant actually is toward the incisal edge, but it has a built-in prosthetic interface that's about 12 degrees. So it corrects it automatically in the implant body. So you can see the base is wider. The right central incisor had a 4.5 to a 3.5 coronal diameter implant, and the left one, which needed a little bit more stability, went to a 5 to a 4 design. The key, like I said, is opening the embrasure adequately and then doing the interproximal grafting. It's very important to do the dual zone grafting, but do it interproximally as well. Again, you want to create the space for the papilla. I've made mistakes before, like I said, I'll show you that if you don't create the proper space and the papilla doesn't have a chance to reform, then you really don't have the ability to retrieve it later on. Again, getting the primary stability, angling it toward the anatomy of the socket, but then the prosthetics allows you to do a screw retain restoration. So again, 1 week and then 7 months of healing in this situation. We made a second set of provisionals because I wanted to sculpt the tissue a little bit more because she had a flat gingival profile. You can see blanching when I inserted the second set of provisionals, but we want to push the tissue to create more of that 40% gingival scallop. So these are with our second set of provisionals because I'm trying to condition them. And I also made them as 2 separate units, which would allow me to really work on the contact area, like I said, which is so critical. So that's with the first set of provisionals, but you could see how I'm able to push the tissue and actually create more of a scallop to create the illusion that I actually have a longer papilla. And that's sort of the papilla game you can play with contour. Again, we just did metal ceramics, 2 single metal ceramic crowns that are screw retained, layered ceramics, and then trying this. And I just saw the patient, she's moving away, but you'll see this is the day of insertion, and this tissue will migrate down more coronally, but you could see how the papilla is all even in height. Where I've fallen short, like I said to you before, is that I used to do this implant pontic, thinking that maybe we could maintain this papilla with an implant pontic relationship and then maybe stage putting a second implant later on. But what I found is that because this is a pontic, I didn't want to compromise the strength of the interproximal connector, that what I wound up doing is not having enough embrasure, and I wound up compromising the height of the papilla. You can see here at the time of surgery and how the papilla is blunted. And unfortunately, I was never able to recover this, even with modifying the provisional or even then placing 2 implants and staging the implant. The papilla is still short. So I'm no longer in favor of actually doing this implant pontic and staging it, thinking that I could preserve the papilla, because what you wind up doing is you wind up making the connector too large because you don't want the pontic to break off, and you're winding up compromising your papilla. So I think it's just better to go with 2 implants right off the bat, like this particular patient, central and lateral situation, basically resorbed roots. We're going to use a straight implant here, but a coaxial implant there. And then again, we didn't have really this hybrid implant, a straight version, which this left central needed. And then the lateral, we did a coaxial version where, again, you're drilling toward the incisal edge. This is the surgical drilling, but the prosthetics is already built into the head of the implant. You just have to orient it. Again, interproximal grafting, that's critical. So we want to graft the interproximal to try to encourage the papilla to be there. And again, 2 implants done immediately and creating enough embrasure space so the papilla has the opportunity to form. This is at 6 months. You could see we probably lost a little bit of the papilla to be, very critical. She wound up bleaching her teeth over here, but you could see here that we have the interdental cull, we have a buccal and lingual peak of papilla, and it's all in a straight line. So I think that's really critical. So like I said, I'm no longer really thinking about staging it and doing an implant-pontic relationship. 2 single metal ceramic crowns, screw retained. You could see here again, we have the interdental cull, and this is at the time of inserting the 2 restorations. I think that we got a pretty reasonable result over here. And you could see, again, the 2 implants. Again, I would prefer a smaller necked implant because, again, the wider topped implant, I think, just compromises bone. So I think, again, these are just some of the strategies we're now thinking and how we can manage this. What I do want to finish up is this one case because it leads into what Sanjana is going to talk about. Stefano had treated this patient who had crown lengthening, pin buildups, and then it broke again. The patient had probably bruxism and other issues associated with the patient. This is with Matteo, where they're doing actually socket shield, but again, using a hybrid implant design in this situation. Again, doing 2 screw retained implants, as seen over here. They did a very nice job. He doesn't have the final follow-up of the insertion, but you could see here with the socket shield, they really did a nice job of maintaining that interproximal papilla with 2 implants. And the question is, will the socket shield really maintain this interproximal peak of bone? I think it leads very well into what Sanjana is going to talk about. So in conclusions, in regards to the interdental papilla aesthetics, it's visible, say 90 to 100% of the time. So I think it's very important that we manage it extremely well. It's roughly 40% the length of the tooth from the gingival zenith. Maybe it's a range of 30 to 50%. That centrolateral case I showed you was a highly scalloped gingival form, and maybe it's like 50% in that regard. They're all equal in length, so that's sort of your parameter to make sure that they're equal in length. And the contact area to embrasure space relationship, I think, is very, very important. I hopefully made that very clear. We need vascular bone formation around the implant on the labial side, as well as between the 2 implants and the tooth to implant relationship as well. Socket shield, maybe it's going to help us do better. So again, Sanjana is going to talk about that. And I am in favor of immediate post-extraction socket implants in regards to implant-implant relationships. And with that, I just want to end and say, avoid immediate implants with pontic implant scenarios.
Thank you very much.
I look forward to the discussion.
Steve, thank you. Thank you very much. I would like just to ask you, do you believe that the tissue phenotype has a role in the success of such treatments?
Definitely. I mean, if you have a thick flat and you have a 30% papilla height, I mean, everything is working in your favor. I mean, that's why I showed some different cases, because that central lateral was actually a thin phenotype. The question is, what will it look like in 20 years? I have no idea. But I do think that with immediates, we have a better opportunity. But definitely phenotype plays a big role. You got thick, flat tissue, by all means. Thin, maybe that's the indication for socket shield, something to consider and discuss.
Yeah, we will definitely, but the problem is always that socket shield is something that we can implement only if we have a kind of a healthy root. Periodontally involved teeth are not candidates.
Absolutely. Yeah, I'm sure that, look, I don't do surgery, and I think that's a great point of discussion, but I'm sure there are cases of teeth that you've removed that you said, maybe if you did socket shield, the root was diseased and maybe you don't want to keep that. Yeah. So these are all things that are open to discussion. And I think that the technique is much more refined now, but I think we need to figure out, well, which teeth we would keep. I mean, when you think about it, you're taking out teeth to do implants because there's something wrong with the tooth. So the question is, the pushback for the socket shield is, well, why would you keep part of it if it's diseased? So I think it's a great discussion.
Yeah, because
But
I
we've
believe
done some cases, and
Yeah.
it works in certain instances. Yeah.
Yeah, I do agree, but I believe that the diagnosis is very, very important. And if we diagnose a situation with periodontal disease, then we might take another route. The other thing that I would like to ask your opinion before we move to Snezhana is how often do you graft in your practice soft tissue in such situations?
It's a great question, and Dennis is a periodontist, as you all know, with perion pros, and he really likes doing connective tissue grafting. But what we found is that with the dual zone technique, if you use a small particle cancellous mineralized allograft, which resorbs, that you can actually get the same outcome as connective tissue grafting. What we did is we compared the outcomes with what we did and Joe Kahn, who reported that you gain about 1 millimeter of peri-implant soft tissue thickness with a CTG.
Yeah.
And we found that we gained about 0.9. It was very similar. So Dennis's whole philosophy is that he just wants to do something, sort of simple, quick, and efficient.
Yeah.
So for him, as you know him very well, is that, well, it would take him probably more time to do a CTG, but he says he can get the same outcome with grafting. So he just says, I'd rather graft because it's faster and easier.
Yeah.
So I said, I'm okay with that. So, it's just preference, but he does do connective tissue grafting as a periodontist. He just feels that this is easier and faster. But you got to use the right graft material. If you use the wrong graft material, it becomes a big problem.
I
Because
agree.
xenograft materials just stay too long. If they have a thin phenotype, it just becomes a big problem.
Thank you so much. Please stay with us because we have a
will.
very interesting discussion at the end. Let's move now to Croatia. Snezhana, you're most welcome to set up now the stage. Woman power, please.
Thank you. Thank you, Nathan. Thank you, Quintessencial, for this invitation. I'm really honored.
Your audio is very low. I think you have to turn up your microphone, or your microphone is very low.
How when we tried before this webinar, it was
It's still very low. I don't know what happened. I'm sorry, but your audio is...
I don't change anything, actually. So maybe if I talk very loud, no, still not. Maybe again. Is it better now? No. Is it better now?
We will try.
Can you hear me?
Yeah, but it's very, very low.
Very low. I really haven't changed nothing in the settings, and it worked very well. I'm so sorry.
I would suggest to continue, and we will see if it gets worse. We can try to figure something out.
So I will try to talk more loud. Okay. I wanted to say that I'm honored and to be part of this Quintessencial webinars and thrilled to share the stage with these legends. And above all, I'm excited to get this opportunity to talk about this very important topic, and this is partial extraction therapy. So I hope really you can hear me. So let's see if I can convince you in these 20 minutes that partial extraction therapy is the solution for the central lateral dilemma. So I'm going to focus on socket shield. Socket shield is intentionally retained healthy part of the buccal part of the root, the healthy periodontal ligament. An implant can be placed immediately or delayed. This is one of forms of partial extraction therapy. If socket shield is performed to maintain the pontic site, we talk about pontic sheet. And if the entire root is submerged, this is root submergence therapy.
Dr. Paul, I'm very sorry, but let's try to fix the audio. If you go to the bottom left corner, there's the icon for the microphone. You see that?
Yes, yes.
If you click on the little arrow next to it, and there's audio settings in the Zoom setting. All the way on the bottom, there should be. Let's stop this real quick. And then if you go to the bottom of the screen, there's the little microphone to the left.
Yes.
And there's a little arrow next to it. Click on that.
Yes.
And there's audio settings, the very bottom.
Mm-hmm.
If you click on that,
yes,
you should be able to increase the input audio. Do you see that?
Yes, input volume. I'm
Yes.
just going to, but it is on automatically. And now
Perfect.
Oh, okay.
Perfect. I'm very sorry, but now it's perfect.
Okay.
You have to restart your presentation, please.
Yes, share screen again. And now I don't need to talk so loud.
Thank you very much.
Anyway, I'm really excited about the opportunity to talk in front of such a huge audience about this very important topic, and this is partial extraction therapy. I'm going to focus on socket shield for adjacent implant placement. This is one of the forms of partial extraction. We do have a socket shield, a healthy part of the buccal part of the root with a healthy periodontal ligament. If it's performed for the pontic site, we talk about pontic shield. If the entire root is submerged, this is a root submergence therapy. So, socket shield is not simply a non-resorbable bone substitute material. Socket shield has a lot of life. It has a periodontal ligament, and this is the main blood supply source to the buccal bundle bone, also to the proximal bone, and also to the peri-implant soft tissue. And it has also some dentogingival fibers. Of course, a proper case selection, as all of you already mentioned, is very important. Yes, this is a limitation of the socket shield technique. It is limited on socket type 1, intact buccal bone. For the teeth with mobility less than 2, for the roots without external or internal root resorption, and without periodontal pocketing on the buccal. These are pre-requirements for socket shield therapy. So one of the most frequently asked questions is about mid and long-term results with partial extraction therapy. I can't show such a long-term results because the first proof of principle was published 10 years ago by Hürzeler about socket shield therapy. But meanwhile, we do have studies showing mid and long-term follow-up, very important from Gluckman, Salama, Dutoy, evaluating 128 sites. And I want to emphasize aesthetic zone and posterior sites, because partial extraction therapy is not limited on aesthetic zone. Why should it be? They haven't found any difference in complication and failure rate compared to conventionally placed implants, and also 5 and 10 years results from Siorompas and his team. Socket shield is shown that it maintain the rich maintains both hard and soft tissue almost completely. Here are some numbers from 5-year follow-up, a prospective study from Boima, showing the mean orofacial change less than 0.4 millimeter. There is peri-implant bone loss on mesial is 0.3 millimeter, and on the distal less than 0.2 millimeter. Great numbers. Let's take a look at recessions 5 years after the procedure was done. Yes, there is some recession for the implant with socket shield, but look at the adjacent teeth. They developed even a little bit more recession. It was a natural aging process. And meanwhile, we do have a nice prospective clinical trials randomized comparing conventional flapless immediate implant placement with socket shield technique. And all these studies are showing that cases with socket shield perform better in all periodontal parameters. Socket shield is important for the single site, but its really beauty is in adjacent and multiple implant site. How is it? Why do we see this tissue quality and quantity each time predictable? Of course, if indication is obeyed and the procedure done how it should be done. This is what already Dr. Chu emphasized. The papilla height between implant and the adjacent tooth is determined by the bone peak on adjacent tooth. That is between two adjacent implants. There is no papilla peak. But if we perform any kind of partial extraction therapy for the multiple size, like submerged root or socket shield or pointed shield, these sites behave almost like natural teeth. They take care about the bone peak. But it's not everything about the hard tissue. It is also about the soft tissue. This is what Linde and Berglund has shown already 25 years ago, that peri-implant soft tissue, peri-implant connective tissue has a poor blood supply because blood supply from the vessels of the periodontal ligament is missing. And if we retain at least a part of this periodontal ligament and of dentogingival complex, we see regularly results like this. So I'm not going to show any adjacent implants for the central incisors, and also not for the central and lateral if there are not teeth on contralateral, natural teeth, because we want to compare. Dr. Chu has shown the literature, and here in another paper that the authors have found out that if the famous 5 millimeter rule from Tarnow is not kept, that then the papilla between central and lateral incisor is more likely to be insufficient than papilla between two central incisors. So I'm going to show only cases central, lateral, adjacent implants, socket shield, and natural dentition on the contralateral side. So in this case, we start already with some papilla insufficiency. The tip of papilla is not here between central and lateral incisor on the left. Radiogram is showing that about 2 millimeter vertical bone resorption between lateral and central incisor is already here. We plan to place 2 adjacent implants with 2 socket shields. Densaburs to get a better primary implant stability. This is the patient with provisionals, and this is the patient when the treatment was finished. We can see that this papilla improved, but still the tip of the papilla is not here, but it changed. In 2 years, it changed, and this is how it looks like 2 years after the treatment was finished. Again, we start with completely insufficient papilla between central and lateral incisor, and we can see that it improved at the end of the treatment. Simple 2 adjacent socket shields, post-extraction implant placement. Now one can hardly tell that it is the same patient, so I uncropped the images, and his mistake is evidence that it is the same patient. Another case here, we already start with about 3 millimeter missing vertical dimension of the bone between central and lateral incisor. And nevertheless, without any orthodontic extrusion, I helped myself with a dental graft also to support the papillas. This is how it looks like for the patient. It works obviously for 2 adjacent implants and 2 socket shields. And does it work if we have only 1 socket shield and 2 implants? In this case, I planned actually to place 1 implant with the pointing, but patient has a low smile line. She's a colleague and she told me, I don't care about papilla, I want to floss properly. So the central incisor has a buccal bone, and immediately implant placement with socket shield was planned, but on the lateral incisor, there was a buccal bone deficiency. So here I prefer to stage implant placement. This is what you already mentioned. These roots, they look really, really not healthy. But eventually, when socket shield is prepared, we keep the healthy root substance. This is like when we remove decay to do some fillings. If we are not able to retain just a healthy tissue, this is not indication for socket shield therapy. Then we go with alternatives. So for the lateral incisor side, the Maivan technique was utilized, utilizing a pedicle connective tissue graft, and this is how the patient looks after 1 year, and this is how stable her situation is 3 years after the treatment was finished. All these cases had more or less flat gingiva biotype. And look at this biotype, look at these root prominences, look at this scalloped gingiva. It is more demanding, especially when we look at the CBCT. Can I take advantage of partial extraction therapy in this case? Is there enough buccal bone to do socket shield therapy? In some cases, we don't know, and this is what also the literature confirms, that in some cases we cannot see for sure if there is a buccal bone or not. But I really didn't want to miss opportunity to utilize partial extraction therapy. So the apical flap is elevated. Not marginal gingiva is elevated with papilla because this is a trigger for the bone resorption, but apical flap elevation in order to do a proper degranulation of the apical areas and in order to visualize the bone above central and lateral incisor. So there is a buccal bone on the central incisor and only a narrow buccal bone bridge for the lateral incisor. But still, for cases like this, we can apply a proximal socket shield as introduced into the literature by Joseph Kahn. Immediately after the implant placement, and now I take care about the periapical areas, all green dentistry, autogenous bone chips, my favorite membrane, a cortical tuberosity bone plate. The patient immediately after the implants were placed, and this is how it looks like after the tissue maturation. This is how papilla between central and lateral incisor looks like. And this is CBCT taken after implant osseointegration. We can appreciate that the defects are resolved completely, and we can appreciate the amount of the hard tissue. It looks stable. It looks like it's going to last. This is a clinical appearance. Look at the papilla between central and lateral incisor on the left, 2 adjacent implants, and on the right, tooth and pointing. It looks even better. Of course, one must know about the procedure, about the biology behind the procedure. And no one of us starts to do sinus lift elevation or bone blocks without get educated, without having a course. And this is the same. Of course, what should be done when we start to apply partial extraction therapy. If you are interested, if you want to read about step-by-step procedure, how to perform socket shield, recently this great paper is published by Harvey Gluckman, Jonathan Dutoy, and Maurice Salama, all friends from my Dental XP partial extraction therapy research group. And also the book, Partial Extraction Therapy, edited by Udata Kerr and Ali Tunkivala, also friends from my PET research group. And very soon, let me announce, my app is going to be available, implant surgical procedures for socket type 1, 2, and 3, area. So now let's talk about complications and failures. Here I borrowed this nice overview from partial extraction therapy group. Of course, first of all, diagnostic errors, wrong case selection, error in assessment of root condition, of radial position of tooth, and assessment of buccal bone morphology. Of course, surgical errors, error in preparation of shield mobility. If shield get mobile during socket shield preparation, it must be removed. Apical bone fenestration is easy to manage, palatal wall fracture never seen, the same like post-extraction implants, and this is topic shield implant proximity issues. Namely, if we place our implant in contact with socket shield, during the implant placement, it can happen that shield fractures or get displaced. This is why we prefer to have a gap between implant and socket shield. And then, of course, complications in the restorative phase, like shield mobility. It is always for the shields that are prepared too short, that don't have stability, shield migration and shield exposure, internal and external. This is what Gluckman, Salama, and Dutoy has shown in their study, that internal and external shield exposure are the most common complications. Internal shield exposure means that there is not soft tissue seal, there is not soft tissue between covering the socket shield. The prosthodontic components are in contact with socket shield. The safest way to avoid is to prepare socket shield on the bone level and to thin out the coronal part of the socket shield. At least 2 millimeters of soft tissue seal is required. This is from Richard Martin, also from my group. And then we do have external shield exposure. It means that gingiva above the socket shield opens. Again, no sharp edges, socket shield on the bone level. If marginal gingiva is elevated and the buccal bone is very thin, we need some veneer grafting. Both of these complications, external shield exposure and internal shield exposure, are handled rather easy. We just need to trim exposed parts of the socket shield well underneath the gingiva, well underneath the mucosa. I never like to finish my lectures with complications, so let me show my closing case, a very nice patient with a big problem for the central and lateral incisor. The central incisor is fractured and there is no buccal bone at all, and there is a huge periapical area for the lateral incisor. Well, these teeth don't look very much like candidates for the socket shield therapy, but when I prepared socket shield for the lateral incisor, only nice, healthy looking root substance is left in place. And proximal socket shield again was prepared for the central incisor. Now, I don't feel like placing implants immediately into this situation. Buccal bone is not here, huge periapical areas. So it is stage. First, ridge preservation and then implant placement, Glocka procedure. I utilized Myvan technique for the central incisor site. Here you can appreciate icon-shaped membrane like published by Tarnov, and the sockets are grafted with the dentin autograft. Palatal pedicle flap utilized to cover the socket opening, grafting material, and at the same time to augment the buccal soft tissue. This is how it looks like after 3 weeks. And this is CBCT after 3 months. Defect resolution and nice ridge dimensions. Now I can place the implants flapless, guided, and you can appreciate that when the patient had provisionals, the papilla between central-lateral incisor was even better than on the contralateral side. And let's see the case when prosthodontic was finished. This is how it looks like. When we look at CBCT, look, these implants with socket shields, they behave, they look similar to the natural dentition. X-rays. Well, it is really strange to see these roots on X-ray, but when one sees results with the partial extraction therapy, one falls in love with X-rays like this. So, whenever possible, preserve, don't reconstruct. Extract partially, keep the good, lose the bad, and follow the PET rules. A proper case selection must be done, and surgical and restorative protocols must be learned and followed. So I'm really happy that partial extraction therapy is about to be accepted as being self-evident. So I've been talking to you from the beautiful city, the island Krk, in Croatia, and I want to leave you with a smile on your face. I will show you my stage. So,
Thank you very much, Sinjana. It was a very, very interesting lecture.
thank you.
I think that many of our audience are not very familiar with partial extractor therapy concept, and we will probably discuss it later on. I just wanted to ask you, according to your experience, if you have the possibility to maintain or preserve the proximal component of the root when you have adjacent implants to be placed, will you maintain both proximal roots, or is it enough to maintain only one in order to support the tissue through the Sharpie fibers?
Actually, I would like to preserve both of them because it is double security. But as I have shown, these are only cases with 2 adjacent implants when on contralateral natural dentition is here. It works also, and you already gave explanation if there is only one of them. There's a socket shield. It is enough.
I understand. The other question that I would like to ask you is, do you believe that if you have an implant configuration like Dr. Chu was showing, where the head of the implant is narrower and enables a larger gap between the implant and the root fragment, would you consider it as an advantage, or you don't think it is important?
It is important to have a top of the implant narrow, an implant is placed about 1 millimeter underneath the socket shield. Okay. When we go with our emergence profile, it's very important that the abutments have a narrow transgingival part.
Yeah.
And this is a problem nowadays with T-bases because very few companies have understand the problem, not only for partial extraction therapy, but in general. And they offer just T-bases 0.5 or 1 millimeter or nothing at all. So it is advantage.
I understand.
To avoid internal shield exposure, shield displacement during implant placement, absolutely.
So would you say that those people that are implementing the socket shield concept are better using specific implant designs and prosthetic components to enhance the result?
Yes. What is important to use more narrow implants, already said, the narrow abutment,
Yeah.
the platform switched implants. Important.
Thank you very much.
Well,
We have now the pleasure to jump to Great Britain, to Windsor, where Titu Manku will finalize the lectures, and then we go for a very interesting discussion. Titu, how are you doing over there?
I'm very well, thank you, Nitzan. This has been a very interesting session. So, Jana, let me congratulate you. That was wonderful. Thank you. Very interesting. And Steve, great job too.
I see that you didn't have a lot of time to change.
No, I'm still in my clinical gear. So it is the end of the day here. It's early. Remember, we're an hour before you guys, or 2 hours before you.
2 hours before
Yeah,
Tel Aviv.
Yeah.
Yeah. Okay, go ahead, Titu. We are with you.
Okay. So let me share the screen. How is that? Okay?
Perfect.
Great. So it's a great pleasure and an honor to be sharing this webinar with very good friends and colleagues. My role to close out is basically to finish up with just sharing some of my experience with long-term experience with immediate adjacent implants, and maybe just touch on a few other things that we'll be able to just share briefly towards the end if we have sufficient time. So the key thing is to always remember that when we come back to thinking about implants, there are certain key principles that we must respect. As you've heard already, the correct positioning of the implant, the design, size, and so on are important. Making sure we maintain adequate volume of the bone in order to support the implant and surrounding soft tissues. And as has become very clear in the last couple of decades, is that the soft tissue has a very important role to play in terms of maintaining the aesthetic outcome. Jana mentioned also about the importance of the abutment design, having a narrow emergence, concave profile, and we tend to like to try and place our definitive abutments earlier in the whole scenario to improve the biologic response and to maximize the biocompatibility of the transmucosal components to allow for the optimum adhesion of the soft tissue and maintenance of the biologic width coronal to the implant. And of course, to have the appropriate contours. And there are some details. Feel free to take a quick screenshot with your phone or whatever with these slides, but there are some things that we like to focus on. And I'm a great believer in the biocompatibility of the materials having a role to play and making sure that the transmucosal components are clean and disinfected so that we maximize the ability of the soft tissues to adhere and to have an appropriate and optimized biological response. And I agree with Snejana that we have some challenges with the tie bases because Now we are bonding materials below the gingival tissues, and I'm not sure of the long-term health of that, and also the shape and the profile of some of these components is not ideal. So let's just quickly look at the management of failing teeth. As Steve very nicely pointed out, some important parameters, but there are some things that we need to figure out. Of course, when is the indication for an immediate implant? We tend to prefer if there's no acute infection, even though there are some papers that do support the placement in infected sites. But I think in my own personal experience, we've seen a higher degree of complications and failures in those situations. And we like to do a flapless approach combined with a gap filler. And I prefer still to use a connective tissue graft in most cases, unless we have a thick biotype. You can, of course, choose to open a flap, but I think you negate some of the advantages of the immediate protocol if you do that, albeit that placing an implant immediately into extraction site requires a higher degree of skill and I think experience than you would have if you have an open flap. And of course, we delay things if we have unfavorable situations or think about alternative approaches, as already been mentioned. There's been a good deal of literature about immediate implants and some of the things that we can do, but I'll summarize the conclusions really to say that we try and do it flapless wherever possible, but if you do raise a flap, then you must do an augmentation, because raising a flap will create more remodeling of the soft tissues and loss of volume. We place implants away from the buccal in a similar way as we do with the socket shield. And we tend to use in aesthetic zone, narrow or regular platform implant, and really not using anything wide. We like to place a bone mineral. I'm not sure whether we need it to be anorganic bovine bone, but historically this seems to be more effective at maintaining volume than some other graft materials. But I think we may be changing our opinion on that as we go forwards, but let's see. We like to thicken the soft tissue, particularly when we have a thin tissue biotype. And it seems to be advantageous to provisionalize the site immediately. Now, it doesn't have to be necessarily on the implant. It can be with a pontic, which is placed over a hollow pontic placed over a healing abutment and supported by the teeth. But it seems to have an advantage in supporting the soft tissue architecture. So our aim is really to preserve soft tissues as much as possible and avoid the need for reconstruction and prosthetic placement when we're utilizing immediate protocols. We understand the limitations of the papilla in terms of immediate placing implants into healed sites, that we always have a limitation in the size of the papilla because of the inadequacy of the soft tissue height initially. And if we're going to do this, then we really need to over-augment the site in order to scallop it adequately, which requires a more invasive and surgical approach. So many years ago, we had some experience with immediate placement into multiple implant in sockets. And I want to share some of this experience with you from a few decades ago. And going back to one of our cases in that paper, showing a couple of teeth that were failing. We had cracks in the roots. The patient was referred as post-crowns had been repeatedly decementing, and the dentist saw that the roots were cracked and referred the patient to us for implant placement. We decided to do immediate placement in the ways that you've been shown: implant to the palatal, gap in the filled with the anorganic bovine bone mineral, and immediate provisionalization. And in this case, we did not use a connective tissue graft because even though she has a thin biotype, we actually wanted to lengthen the clinical crown because of the short looking teeth. And so you can see on the left side, the original, the provisional in the middle, and the final at 6 months. And we wanted a crown lengthen, and we also changed the veneers on the laterals. But what is interesting when we look back at this case and we look at the radiographs, we can see the starting position of the bone relative to the adjacent tooth. And we see how at 1 year, the bone peak between the implants is being maintained. And at 6 years, we see the bone peak is still at the same level, and the papilla is completely maintained in the original architecture. What about the long term? And of course, now 15 years later, the patient is now in her early 60s, and she is obviously has had age-related changes. But you can see that actually we still have a reasonable scallop form. The tissue is thinned, and probably we should have done a connective tissue graft in the first place. And what's interesting is we can still do that now with a tunnel technique, augment, and this is now the 17-year follow-up. And what I find very interesting is that that bone peak at 17 years is still pretty much at the same level as the adjacent teeth on either side. And so there's been very little loss of the bone. There's been a little remodeling, but in 17 years, of course, a patient's age and things change. And so we postulate that maybe these alveolar fibers, the alveolar gingival fibers and the interpapillary fibers may possibly have a reciprocal effect on the bone. In other words, when we support the soft tissue, perhaps the tissue also supports the bone. We don't know. Some papers say that, you know, the extraction socket remodels anyway, the implant doesn't make a difference, but I don't think we really looked into this particular area. And I think there's nothing in the literature that really talks about it. So let me whiz through a few more cases, a similar sort of scenario, a couple of failing teeth. We placed with asymmetrical gingival margins, and we did careful extractions, placement of the implant, palatal. These are an old scallop design that was popular for a while, many years ago. We didn't really find any advantage to it, but it works fine. And a little bit more difficult to manage prosthetically. And you can see that we grafted the gap. We didn't use a connective tissue graft here because we had a significant thick biotype. And you can see the final restoration, cement retained crowns in this case. And you look at the case following up 1, 4, and 10 years. And you see, again, pretty good stability with the maintenance of the architecture in this case. Another case, very complex case with patient with thin previous endodontic treatments, very dark roots. And you can see 2 failing teeth. Interestingly enough, this tooth was actually asymptomatic. This is the one with the problem. So the dark tooth was asymptomatic. The light tooth was problematic. The patient wanted to do something about the blue-looking gingival tissues, and really the only thing we could suggest is to extract the teeth. So the first thing we did is provisionalize the case, do some composite bonding on the laterals, and provisionalize the case to get the proportions of the teeth looking a little bit better. And then we took the case through, sorry, the wrong way. Then we took the case through to extraction, placement of some implants with gap filler, connective tissue grafts, a Rochette type provisional bridge, and then a couple of cement retained restorations. These days we tend to go screw retained, but historically this is what we did in those days. And you can see the follow-up. And again, it's interesting to note the 1 year, 5 years, 11 years, and 14 years. And what's really interesting is you see how the diastema, and we can talk about this there later, Nitsan, you see how the diastema is increasing over time. And this is something we see that, you know, patients have age-related changes that affect the way that the soft tissues change. But you can see a beautiful, healthy result. I think the connective tissue graft makes a big difference in terms of the quality of the soft tissues, and a very healthy looking soft tissue there. Another case, similar sort of scenario, thin biotype this time, with a patient with 2 failing teeth due to root resorption. I'm sorry, let me just go back. You can see the roots after removal. So we have actually a lot of bone because there's very short roots. And we use the patient's own teeth as provisionals. And you can see now the implants in place and the final restoration. And again, 1 year and the 5-year follow-up. And this patient was a referral, and I haven't been able to get any longer term follow-up, but I understand that everything is fine, having spoken to him on the phone. but I would like to see him again. So we have a couple of centrals. What about more complex cases with perio history and so on? Well, an example of a case that we treated back in 1999 with rather complex therapies and perio, multiple implants, and the patient had provisionals on for a long while. You can see the healing abutments at the time of surgery. After 18 months of provisional, we can see the slight recession, but the maintenance of the interdental architecture. And because we have titanium, a biocompatible component, you see the nice bleeding tissue here and the maintenance of that supportive tissue. The final result, again, at 3 years follow-up and looking at the improvement in the bone levels, but particularly in the smile. Steve, I think you'd like to see these papillae. And unfortunately, I wasn't able to follow this patient up any longer because she developed an illness and died about 18 months after I saw her at this time. And so we didn't have a longer term follow-up. But this is the 3 years, and you can see what's really interesting is little peaks of bone being maintained between the teeth at 3 years. Then we look at a more complex case with a thin biotype. And again, this is one of our early cases. And you see what's interesting in this case is, just to think about the different options that we might have. And I think the patient stipulated that he did not want any bridge work. And because our initial treatment plan was to either do a 6-unit bridge from canine to canine, which would have worked perfectly well, or to place 2 implants and do a bridge. The patient wanted to have individual single teeth. And so we discussed the options, and you can see the placement of the implants. In this case, we used a wide in the central and a narrow, a regular in the lateral, because the patient was a very large man and had very big teeth and big sockets. And in order to get primary stability, we needed to use a slightly larger implant than normal. And we provisionalized with a bridge supported. And here's the before, and this is the 2-year post-op. And it's interesting just to compare the soft tissue and how little there's been change in any of the soft tissue between the before and the after. 1 month and 5-year follow-up radiographs show, again, very, very little change. This is the 2.5 year, the 5 year, and this is the 9 year. And again, this is a referral case. And despite many attempts at trying to get the gentleman to come back, he says everything is fine and he doesn't want to come back and see us because he lives far away. And so this is the longest follow-up I have, but it's now been about 17 years since we did the treatment, as you can see. And he is quite stable, I am told. So are there situations where we wouldn't do it with a flapless approach? Yes, there are. And maybe when you have a complicated scenario with failing teeth, periodontally and structurally and endodontically compromised, we can raise a flap, carry out a GBR, and at the same time graft. And we will end up with a slightly flatter gingival architecture, taking the patient through to the final restoration. And you can see, again, the initial, the 5-year, 11-year, and 15-year follow-up. Note there was a periimplantitis on this lower right premolar, which was treated. And of course, this is a risk in all patients who have a periodontal history, as we well know. And you can see a close-up view of the anterior teeth and a stability, but a flatter gingival profile in such a case with the surgical approach. We've already spoken about partial extraction therapies. I will just share one case where we felt it's very appropriate. A patient with a complex situation, very deep bite, and already lost a lot of teeth with some very compromised situations with loss of bone. And you can see the scenario here, and clearly needs an interdisciplinary treatment plan, which we did. When we evaluate the CDCT, you can see what we're dealing with in terms of the volume. Let me just speed this along to the other side. And here we have 2 problems. We have a lateral incisor which is root resorbed and fractured. And then we have a canine, which has also got external root resorption. And next to the canine, we have a large defect, which is in this area on the upper left maxilla. So we provisionalized the case, first of all, with starting to place some implants and grafting and augmenting some areas to prepare us. And we kept the resorbing canine just intermediately because I needed something to support the provisional. And, but we know that that tooth is failing. We carried out a socket shield on the lateral incisor. You can see the canine here, which we maintained during the provisional phase of the treatment. And then we converted the bridge, as you can see, with a Rochette wing on this molar, hollow pontics on the healing abutments, supported in the canine and central. So we have to be a little innovative in our designs. And you can see how we manage that. Patients now having orthodontics. We change the relationship, and then we can extract or decoronate the canine, carry out our partial extraction therapy with a socket shield for the canine. And now we have an implant also placed in the canine with a socket shield. And it's interesting to see, as we take the patient through the various steps, nice maintenance of volume, as St. Jonas showed already, and the provisional restorations, and then the final outcome. And what's very nice is to show that we have a lateral and canine on the implant side, which is pretty much identical to the soft tissue around the natural canine and lateral on the contralateral side. And I think we would have struggled to achieve such a result, particularly when we look back and see the fact that we had already missing teeth with a large defect in the premolar region, which we had to augment. And whereas if we had also lost the canine, we would have had a massive loss of volume in this side, because the canine is a very important tooth in supporting the horizontal volume of the alveolus. And you can see a close-up view at 5 years of this, and how it seems to be maintaining itself very nicely indeed. Nitsan, how are we doing for time? Have I got time to show an ortho case?
My side, it's okay. We don't have restrictions. If Nitsan's okay, go ahead.
Okay, so I'll just continue. I'll presume that he'll interrupt me if he doesn't want me to. So sort of taking things further to sort of more complex situations where we have these periodontally involved cases, as I've published and shared on many occasions. And I guess some of you may have seen some of this material before, but we understand that implants can be successful in these cases. However, we should expect to see more frequency of biologic complications over time, and perhaps some bone loss, and of course not to be surprised to have occasionally a peri-implantitis with some of these cases. But nevertheless, it's shown as long as patient can be well motivated and well maintained, that we are able to keep these patients going for some years. We only have time to look at one case, so we'll look at the first case, which is this lady here, who presented after having experienced aggressive periodontal disease following orthodontic treatment, where the dentist did not diagnose the periodontal disease and carried out some ortho. And the patient then presented with this sort of scenario, with massive bone loss and very compromised dentition. I'll be very honest, probably today we would keep a few more of the teeth than we extracted back then, but this was 15 years ago or so. And perhaps back then we didn't have the same information on periodontal literature to save some teeth that we can do now. But even then it would have been a challenging scenario to maintain. So our treatment planning was very much how to manage this asymmetrical bone loss, because if we extract these teeth, we know that we're going to end up with a very difficult unilateral defect on one side, and making it very difficult for us to produce something that's aesthetic without pink ceramic or pink porcelain. And really that presents a challenge for the patient in the long term from a hygiene point of view, which is exactly what you don't want in a patient that's periodontally susceptible. So we try to think of other things out of the box maybe a little bit. And we always treatment plan our patients in the same way, to have a control phase, a corrective phase, a rehabilitative phase with a working prototype, and then a definitive restoration. And then always consider the maintenance phase to be part of the treatment plan, not to think that we finish when we finish the final restoration, but we have to have a maintenance plan for the long-term maintenance of these cases, particularly with those with a history of periodontitis. And we step forward to a concept of reconstructing not only soft tissue and bone through surgical approach, but through orthodontics by extruding roots and bringing tissue and bone into a more coronal position. And this is the sort of protocol in terms of how it runs through the actual treatment protocol. So the first thing is we extract what we considered at the time were hopeless teeth. Perhaps today we would have tried to treat some of those, but at the time this is what we thought. And we then carry out a very thorough infective control therapy, and having cleaned everything up, got rid of the disease, we stabilize things, and we start then to extrude the roots. So this is carried out with orthodontics. Very difficult to do with the lingual appliance, which patient for some reason would not wear a labial appliance, which is much easier to work with in these cases. With the lingual appliance, you have to control the vector of extrusion because it has a tendency to go too far to the buccal. So you must have a compensating elastic to bring the teeth palatally. And as we extrude the roots, we were placing some implants posteriorly. And then we moved over to a different concept of using magnets, which is actually a difficult way to work inside Pontex, but it's what we did in this case. And as we take the case through, you can see us extruding the roots to the point where we bring the bone in a very unusual topography now, where the original bone was up here somewhere, and now we've brought it right down. And you can see now how the roots look before the extraction and the immediate implant placement. And we've placed 3 initially, and then a little while later, we also replaced the other lateral. Same protocol, we did implants of the palatal, gap filler with biomaterial, connective tissue grafts in each of the sites. And you can see I even customized the healing abutments to allow for a little bit of extra space for soft tissue. And then we take the case through to the final restoration, cementing, always using a cord to protect from cement. We're using cement restoration today. Of course, we go for screw retained, which is a lot easier. And we can take the patient through from a scenario like this with 4 immediate implants, and you can see how nicely we maintain the architecture in a more symmetrical form. Is it a perfect papilla? Absolutely not, but look where we started. And then we see the situation as it started and the situation as it ended up. This is at 5 years follow-up. This is now at 8 years follow-up. And what's interesting is you see we are seeing some mineralization in the area between the implants, whereas originally there was a reverse topography here. Now we can see there's some mineral is forming. So maybe when you bring the tissue down, the bone follows, and that's very interesting too. And this is the 11-year follow-up in 2018, and the case completed. And so we were able to treat a couple of cases like this in this paper that we published in the International Journal of Aesthetic Dentistry some years ago. And we use this technique for periodontal cases quite frequently, moving teeth, extruding teeth, or moving teeth laterally into potential implant sites, which is also another option, which we don't really have time to discuss today. So with that, it's a whirlwind run through the last 20-odd years of experience with immediate adjacent implants. I hope that's been helpful, and happy to have a great discussion.
Thank you, Tidu. Brilliant presentation. Lots of material, though, in a very, very
short time.
Short time, yeah. So we need to digest whatever we saw. Christian, let's have all of us on the screen, because I would like to start the discussion if possible. Hi, Snejana.
Hi.
Hi, Steve. Okay, so I just want to mention that whatever we saw here is a variety of armamentarium that we as dentists should be able to choose from and actually implement the right technique in the right indication. So this is very important. On the other side, we saw some very impressive results from TIDU utilizing old-fashioned implant systems as well as old-fashioned prosthetic components. And the question is to all of you, are the new, I would say, more advanced implant systems and prosthetic components a real advantage in the hands of every dentist while treating such situations? Or are they just a matter of hype? What do you think? I would start with you, Tidu.
Okay. Look, I think there is an advantage, and the advantage is this. I think, today I would use a conical design, and many of us are using other designs like yourself and Steve mentioned. I know that the conical design provides us with an additional concavity, which gives us an additional thickness of soft tissue. And I think anything we can do to thicken the soft tissue around the implant neck in that transmucosal area has an advantage. However, when you look at some of those old cases with the so-called, rubbish implants designs, they're standing the test of time. So one has to ask the question, is it really that critical, or is it more about the clinical management and some of the details? And some of the details are, I believe, in all those cases, we used a transmucosal material in the early couple of years of healing, which was biocompatible. So we don't use acrylic temporaries deep under the tissue in the early phases, because a lot of colleagues, I think even yourself, I remember we having a discussion once that you were trying to do the same thing with immediate adjacent implants, but you weren't getting the same stability of the soft tissue. And you'll see that I always place my transmucosal material is always zirconia as a preference, or titanium, but zirconia would be my preference in the transmucosal area, and use only a feldspathic or whatever material you're using, a veneering ceramic in the sulcus, so no more than 1 millimeter subgingival, and you need to try and allow for as much of the transmucosal zone to be in a biocompatible material. So I'm very much against using acrylic temporaries or composite resin materials deep under the soft tissues and to sculpt the tissue. Yes, it looks nice, but then you see that epithelialization. If you look at some of those cases I showed, you saw how the transmucosal area was raw. But actually, that's what I want. I want it to be red and raw, because then I have tissue adhesion. Otherwise, I have epithelialization, which means I just have a deep pocket. And I think that's a factor that affects a lot of our situation going forward. So can I answer the question? I don't think, I don't know if it's so critical, but there are definitely advantages with the conical designs or the narrow designs, in that you have an increased volume at the deeper part, which I think maintains the soft tissue stability better. But then you have the problem of then having to flare out to support the soft tissue. So, swings and roundabouts.
What I noticed is that in the majority of your immediate implant placement, you did place the implants infracrestally, even in those days when you had pretty large implant head. And I believe that this is also...
No, I didn't actually. I mean, if I had an implant with a machine collar, which most of them had at that time, I would place that just supracrestal actually.
Yeah, but approximately it would go in...
Approximately, yeah, very deep. Approximately very deep. Because obviously the scallop of the bone. So I'm talking about relative to facial. But today I would do the same treatment, but I would use a conical implant like a Noble Active, or maybe a new design that's coming also from Nobel.
Okay, okay. So to summarize what you said, and you like supercars, right? Fast
I
cars.
do.
Yeah. So you would rather use the most of the new supercars, but you will not let go some of the classic ones, right?
Well, no, I don't use the old implants anymore. Well, let's be honest. We only use conical connection nowadays, so there's not. I think there's more advantages than disadvantages, and it works better. And I also think from a health point of view, with the newer designs, we see less problems with peri-implantitis, I think, as well.
Yeah, I tend to agree with you, Steve. I would like to ask you, what is the weight that you give to the I would say hardware, because the software is very, very important. As Tito said, the hands and the head of the dentist are probably the most critical components of a successful treatment. But what do you think about the hardware, Steve?
Well, I think it has a role to
No,
play.
I asked Steve.
Steve, sorry. Okay. Yeah.
Sorry.
Go ahead.
Yeah, I don't want to underestimate what Tito showed, that, in the hands of a really skilled practitioner, you could do great things. And just to sort of add to the concept of the hardware, having a reduced diameter top, it's just more forgiving. I mean, the average clinician, Tito, I've seen your cases and it's wonderful long-term follow-up. But I'll tell you, if you're a little bit off in the aesthetic zone, you're just a little too close to the adjacent tooth, or the implants are too close together and you have a wide top, it just kills the bone. And some of them have polished collars, which we know that the bone won't stick to it. And so I was very impressed with the cases you showed with the four centrals, because, you were dead on. But not everybody, but I got to be honest with you, I practice in a group practice with 4 different surgeons, and they're not all the same, and they're all great. But if you're a little bit off, the penalty in the aesthetic zone is huge. So the concept of trying to combine the hardware, diameter and soft bone, but at the apex where you have more bone, or at the top where you have thinner bone, so reduce the diameter. You're not using it anyhow in an extraction socket. You don't want to obliterate the socket. So why make it a problem? So I do think that's where we're heading, because we have to combine the benefits. Yeah.
Totally agree.
Yeah, but the cases you showed, that's because you're a skilled clinician. But for the unskilled or the beginners, I think they're just a little bit more forgiving if the top is not so wide.
Well, I think there's one other advantage that I have, is that I do the surgery and the pros.
Yeah.
I think when you control both aspects,
yeah,
you can compensate for what is going to be a problem later. Whereas, there is a little advantage in that.
Yes, there's a big advantage.
Yeah,
because when you restore, how good of a surgeon you are in placement, because if you don't place it really correctly, you have problems restoring it, even with the provisional. So it's a great learning tool. So I don't know if I answered the question, but I think they're just, I think it's just, they're more forgiving. They just give you a little bit of insurance that if you're a little bit off, maybe you won't kill the bone or the papilla.
I agree 100%. I think that we always need to think about the future, and we need to consider some possible type of failures in the future. And if you have a system that has more abilities either to prevent, or if the catastrophe occurs, to take better care of it, I believe that this is something that we need to think of. And I do believe that there are today some very smart systems in the market that enable every dentist to enjoy them much more than the old-fashioned ones, no doubt. Snezhana, may I ask you?
Yes.
I know that you are a very talented surgeon and not only dealing with partial extraction therapy, but this was your topic today. And I wanted to ask you if you feel that keeping a piece of fruit in every case that is indicated is a must. I wanted to ask you if in those cases that you know that you're going to add a veneer graft, a connective tissue graft, is keeping this fragment a real advantage?
I absolutely think that is advantage because if I can maintain the buccal bundle bone, if I can maintain the interproximal bone, if in the future some adjacent implant is going to be placed, then I don't want to miss advantages of the partial extraction therapy and of the root canal implant in place.
What do you think would be the answer if I would ask, let's say, Maurice or Howie?
The
What
same.
would they answer? Christian, can you check if we can get some answers from those guys?
Well, we'll see if they want to join us. Here's Maurice.
All right, Maurice.
If he chooses to turn on his camera, I don't know if he's wearing any pants.
Who is Maurice, the young brother?
I'm
or
here,
the
guys. I'm not appropriately dressed to put my face on. but I love watching you guys today, and I thought everybody was outstanding. My compliments, and I think Nitzan, you recall that we were together in Tel Aviv, I think 5 years ago, where we had a very nice point counterpoint on immediate extraction in the aesthetic zone, very much to this almost similar panel, but without the great speakers of Stephen and Tidu and Snezana. It was others, but you and I had a very nice discussion on the podium in front of several hundred Israeli dentists, and it's nice to see that that concept now is being brought to the stage with these outstanding speakers all around the world. And my compliments to Quintessence and yourself. And
Maurice, your microphone is blocked.
Oh, I just said I thought it's great that you guys are bringing this to the stage once again in front of an international audience, and I thought that it's very worthwhile. And I think a lot of people are curious about how to take an opportunity to deal with these types of extremely challenging situations in tooth replacement.
May I ask you, Maurice, a question that might not be politically correct, but I believe that many of our peers would like to know the answer. How do you charge for keeping the piece of fruit in place?
In my office, I charge it as an extraction procedure, a surgical extraction. I inform the patient of what I'm doing. I suggest to them that if they're interested in the information in the literature, I point to them. I know a lot of patients these days like to look online and do their own research and Google search. And I suggest that they take a look at it. And I have not had actually, I've had one patient in the last 10 years that didn't want me to do the procedure. One lady in particular that had a particular issue, I think because of her referring dentist. But other than that, I've had a very, very easy time charging for it. I've had a very easy time explaining it to my patients. And I've had an excellent long-term result over the last, really my first case was a ankylosed canine that I know Stephen knows very well because I showed it to Stephen in 2010. And that case is my longest case of socket shield, and it's still doing extremely well, holding up very well.
So you actually do
Yes,
not...
we have Howie Gluckman here. He's the man for this.
Yeah, we'll go to South Africa in a while, but I would like to hear from Atlanta. So in Atlanta, it's a regular tooth extraction with no extra charges for the procedure.
Surgical extraction, yes.
Surgical extraction.
Surgical extraction. And
Great.
yeah, in many instances, you know, I find myself, and again, you know, Howie and I have had an opportunity in our study, in our pet research group, which is really, Snezana was so gracious in you know, making sure she showed it online. I would have to say that those 20 some odd members from all around the world have played a remarkable role in making sure that we conducted our own research and held ourselves accountable to one another. And these were people, outstanding clinicians from all over the world. They may not be common household names like the Mankus and the Chus and the Pichachos of the world, but I promise you, many of them have published, and they're outstanding clinicians. And we share data, and we've collected data together. So it's not just Howie, myself, and Jonathan Dwa, but really a group of outstanding clinicians that have shared this data over an extended period of time. So, you know, I was involved, obviously, with a lot of the research that came out, obviously with Stephen and I having this discussion back in 2006 or 2007. And, you know, I think that there's a role for, still to this day, in certain situations, for us to have to go with some of the concepts that were discussed with Stephen and dual zone and those kinds of ideas. And then Tito actually made a very good comment as well. I think soft tissue plays a role in some cases where the tissue is very thin. And there he is.
So you do combine in certain situations PET and a connective tissue graft.
In a rare situation, it's very rare.
It's not
But I would say mostly in dual zone with extremely thin tissue types.
Okay, Howie, how are you?
I'm good. Always good to see you, Nitzan.
What is this background?
It's my academy.
What is your opinion? You know, you are a periodontist, very, very skilled. How did PET change your implant life?
I think the key factor comes to the two words which I shout at every podium I get an opportunity to lecture on. I say two words, and the two words are predictability and reproducibility. And you know, I think for me, I'm not a bullshitter, and I think for me, I'm very critical of my own cases over the years. And after more than 25 years of placing implants, you get to see your failures. And when you see your patients as often as I do, I follow my patients up yearly. I insist, it's part of my practice protocol, and I photograph it. And when you do that, you start to see how your cases fail over time. And when we have individual cases which are exceptional, which we show, and unfortunately some people show only those exceptional cases and leave their bottom drawer cases at home and never ever show them. And for me, the first time, and there's a lot of different techniques, but you know, I did immediate implants for many, many years, and I did dual zone therapy. We did connective tissue grafting with dual zone therapy, et cetera, and we got good results in some cases, but we didn't get good results in every case. You know, I mean, it was almost like a wing and a prayer, and you hope that it looked good, and then you hope that it stayed good, and it really was frustrating. And for the first time ever, when we started doing socket shield and partial extraction therapy, for the first time now, almost routine. In fact, we spoke about this the other day, the routine has become boring, in that every case gives you the aesthetic result that you would be proud to show on any platform. There's no doubt that you get failure. There's no doubt that you have complications. There's no doubt that the technique has some difficulties that require skill. They require training. They require the right instrumentation. So I'm not trying to be blasé about it, but certainly in my hands, I've never been able to achieve the predictability and the beauty and the success that I'm getting to this day. And I think any stage that I go on, and any person that I ask, and also in our pet group on Facebook, you know, you get amazing stuff being shown by people.
Whoops, you disappeared.
Howie, you disappeared if you hear us.
get into it in the way that we've got into it, come back and say, wow, I've never achieved the same kind of results that I'm achieving now. And I think that speaks volumes, because that's when you have a situation where other people can get it. And that I think is the key, Nitzan, is that when other people can get the same success as the people on stage are getting, that's what makes a technique successful. Not the fact that I can do it and nobody else can do it, because that's what happens with a lot of techniques out there. And I think that's where PET absolutely kills everything else. And I think that's why PET will, although it's taking time, as Nizana says, we've passed all the phases, and we're now at the phase where it seems absolutely, of course, why would we think anything else? But it is one of those techniques where it's wow for me, and it still wows me every time I do a case. I'm still like, oh, phenomenal! I love it.
I will tell you, my concern is always the fact that once you have a winning horse, you might try and use this horse even if the racing stadium is not proper, which means that you might try and keep some routes that are not indicated for that. And this is always my fear. You need to be very, very clear with yourself if you're going to maintain and preserve that route or not.
I think we've been very strong, our group as a whole, and I think everybody that lectures has been clear as day as to what the parameters are. And I think no group has put it more strongly forward than our group in all. I think if you look at all the groups that are publishing on Socket Shield and PET, our group is the only group that is reported complications. Our group is the only group that has spoken about management and what you need to do, what those parameters need to be. We've been very, very clear about it. And I think, and I stand corrected on the stage, but I don't know any other publications other than ours that state categorically and honestly what our complications are, how we manage them, and how it's changed our protocol. And I could not agree with you more, but I think it's important that we understand that what you are saying stands for every single technique that we use.
That's true.
If all you have is a hammer, then everything looks like a nail.
Yeah.
And how often do we see people who develop bone grafting techniques that do that same bone grafting technique for every scenario, even though it doesn't work or what works? And that comes down to the case where they say, right, well, I'm now going to show my one successful case when they've got 10 that didn't succeed because they're selling a product. The key factor here is that we are not selling products. We are selling success for our patients, and that's the key. Yes, do you have to follow the protocols? There is no doubt you have to follow the protocols as closely as possible. If you don't have the right scenario, do not use the technique because you are going to burn your fingers. And that's why it's important to learn. Go and study. There are lots of places doing courses on it. Learn how to do it before you jump into it.
Thank you, Howie. I would like to ask all of you another question. As Steve mentioned in one of his cases, he would rather place today 2 adjacent implants in most of the situation rather to have a cantilever pontic attached to an implant crown. My question is it your feeling as well? And the other question is, if you have the chance to submerge the root under the pontic, would this change your philosophy? So let's start with Steve, and then we go with all of you.
Maurice asked a very good question, and what I failed to qualify was the following, is that in that case that I showed with the implant and the pontic, the study that Maurice had done with Team Atlanta and Dennis talked about having about 6 millimeters of vertical soft tissue height. But that's with the connective tissue graft as an augmentation.
Yeah.
What I was trying to compare is that if I'm trying to preserve the papilla with either 2 implants and extraction sockets or an implant and pontic, I was not successful in the implant pontic scenario because I could compromise the papilla space because I was afraid that the connector on my provisional would be too weak and it would break. So I actually messed up on that. And if I had done 2 implants, I think I would have had a better opportunity to create the proper embrasure space to maintain the papilla. And
But if you have, Steve, if you have, and today we do have very strong provisional materials that can strengthen the connector and the cantilevered pontic. So you can really
or I could reinforce it or something.
Yeah.
Or if the patient has a deep bite, sometimes it's tougher. But
yeah,
and I think the analogy I was making was that, you know, if I had done that as 2 immediate implants, I think I would have been able to preserve the papilla better. That case could have been fixed with an implant in pontic with a connective tissue graft, but it would require remediation. And the mistake I made was thinking that, all right, I didn't create enough space for the papilla, and so let me just make 2 single, you know, implants and open up the space. And the answer is it never came back. I lost the opportunity to maintain it from the get-go, and that's really the discussion. So, and I would prefer not to have to remediate it, but if you remediate it, you will definitely get the height you need, but it requires a thick connective tissue graft like Marisa showed. So I want to clarify that, but I don't know how you feel about it, but just the implant pontic cases that I've done, they're not as nice as the two implants next to each other.
Tidu, what is your experience?
Yeah, I totally agree. I think the mistake is if you place a single implant and you have an extraction site next to it, no matter what you do, Steve, you'll lose the papilla. It'll shrink. So I think, you know, that case is a case where you have to you know, accept that you have to go back and do an additional connective tissue graft later. But in my experience, honestly, I'd probably say that I'd rather do 2 adjacent implants in that scenario. But my number 1 choice would be a socket shield or partial extraction therapy, if possible. But you know, I have to be honest. You know, many of my cases, it's not possible. You know, I've tried it, I've had some failures in cases where we push the boat out, and you know, many times the 2 structure is just, you know, not viable in those situations. So I'm, you know, if it's a single tooth, I don't really see that I will bother to take the risk, because an immediate single tooth is so predictable. It's only when you have, you know, I think unilateral aesthetic zone, like the case I showed, you know, the lateral and canine or central and lateral, you know, important. Those are the cases where the partial extraction therapy becomes really necessary. Similarly, if you have, you know, 4 incisors that were failing immediately, then I think you could also get a very nice result, as I've done for many, many years with 4 immediate implants. Actually, I know it's not the popular thing. People do 2 and a bridge, but, you know, I would be quite comfortable doing 4 immediate still today. And I'd use a different
but Tidu, let's be honest. And Howie did mention it. The skill, the experience, the talent of the practitioner are very important. And
I'm talking about my patient, and I'm treating the patient, so I'd be comfortable with it.
I believe that.
But the pet is without doubt. You know, I mean, I totally agree with Howie that the aesthetic outcomes are just astonishingly good. I mean, and you don't have to. You don't have to do any grafting or anything. You know, basically, you just, you know, it's just putting the implant in with maybe a little gap filler if you feel you need it. You probably don't really need it. But the socket shield is not an easy technique, however, and you know, it's easy to also bollocks it up.
Snejana, I would like to ask you, if you have the possibility to submerge the root under the pontic, and the next tooth is an implant, would you take the risk and cantilever that implant on top of the submerged root or not?
Yes.
Yes, I would. But I would still prefer, if we are talking about adjacent implants, to place 2 adjacent implants with 2 single crowns. It is the patients, it looks better, especially if you have natural dentition on the contralateral. It is different. It is a full mouth rehabilitation, and the patient can floss. This is what my colleague told to me. I want to floss. And one patient told me, I like when I drink champagne when it comes also true. I don't want to have a block with my neighbor. So I would do single crowns, and I would submerge the root. Of course, it has a periodontal ligament all the way and maintain very nice rich dimensions. And please let me go back to the question: if would I still do socket shield if I need veneer grafting, and do we need veneer grafting with connective tissue? We need to do veneer grafting with connective tissue only if we elevate the marginal gingiva and the buccal bone is very thin. In these cases, I add a connective tissue graft. And regarding connective tissue graft, I see in my cases that after 8 to 10 years, where I have done connective tissue grafts and everything was perfect, I need to redo the procedure. They would like to see CBCTs for all of these implants to see the buccal bone. It doesn't stay each time forever. And another problem with connective tissue, I love connective tissue, but another problem is a keloid. Just last week, I had my showcase central lateral incisor, my one for the lateral side, post-extraction for the central, for 5 years beautifully. And now the tissue starts to grow.
After 5 years.
After 5 years, after everything perfect on the radiogram, no proben text, nothing, and not tuberosity connective tissue.
It happened from the posterior palate as well.
Yes.
Although you can always shave it if it is a problem.
Yes.
But I agree with you. It happens in our clinic. It happens after 1 year. It starts to happen. 1-2 years we start to see this growth.
Yes, and they love a lot of tissue, but patients don't like it.
That's true. That's true.
It's important not to use too thick a graft, and that's one of the mistakes that was made earlier on. And also the problem seems to happen more from the palate if you go from the tuberosity. In my experience, we see it more from that. And sometimes it's not just soft tissue that grows. Sometimes you get bony exostosis forming. I've had a couple of cases where I have like a tuber and it's bone.
Yeah.
You know.
Or the
because
the dual zone coming out, popcorn, it makes also the swelling and the problem.
Guys, I would like to come to a conclusion, but we need to pinpoint also the prosthetic importance when it comes to implant restorations at the smile zone, especially when we talk about adjacent implants. And I would like just to verify that all of us agree that the transmucosal component needs to be as narrow as possible before it flares to the oral cavity. Is it right?
Yes.
Absolutely.
So
yes.
This is very, very important.
Yes.
Very important agreement among us. And the other thing that I would like to ask you, do you prefer to have a screw retained or a friction grip restoration on cement retained?
Only screw retained.
Screw. Screw's easier.
Screw is easier, but I have no problem to do a cement retained. You can see we have such long-term success with it. But I would say nowadays I rarely do it. It's nearly always screw, especially because you can have angle screws and all this sort of stuff now. It just makes it very easy to do everything screw retained. I mean, with the immediate placement, that's one of the challenges. Is used to be that getting the screw hole in the right place was difficult with an immediate. So you would have to do a cement retained restoration, but with the angle screws that are available now from many systems, that you've overcome that problem. So screw retained is just easier.
Yeah, I think the one thing we have to be careful of is that, as much as we like cement retained and as much as it gives you the opportunity and options, you don't always cement your own cases back.
No, that's the trouble.
And often what happens is the other person doesn't take the same care as you do. And I don't know how many of my cases have been classic cases that are absolutely stunning, have been destroyed by somebody who just doesn't give a damn, who puts 2 kilograms of of temp bond, and half of it ends up under the gum, and you end up with massive destruction. So I think this is where, we have implant designs. We've got the southern implant coaxial, where we've got biaxial screw channels and things like that, which are essential things for us to use. And I think we have to push to use screw retained, and certainly from a socket shield and pet point of view, you want screw retained. You don't want to have any cement around there wherever you can. So I think it's an important discussion, but yes, cement works, but stay away.
Steve?
I agree. I mean, it's, just the coaxial design that Southern has, works really well, at least for us. There was an interesting paper in JADA that said, if you're not really using guides, or even if you use guides, there's a risk of apical perforation with straight implants, just because of the anatomy of the anterior ridge. Howie did a lot of those studies as well on not just centrals, but centrals, laterals, and canines. And that statistically shows that, we have to sometimes angle them. That's why Tito said in the older designs, he would angle them, but then reside to the fact that he would cement. So now with these angle screw channels, but there's some interesting data that shows that with the angle screw channels, you can compensate up to say 15 degrees, but you can't do 28 degrees. That's just too much. So there are limits with those as well. So, but there's clearly, like, look, you and I, Nitsan, agree that hybrid implants are really the future, because you're taking advantage of different systems and you're combining it into one form. So I think that's where, we need to go. And, that's just
I agree.
help. Yeah, it's a help.
So it's very interesting because we have here 4 continents. We have an American guy, we have a British guy, we have a Croatian lady, we have a South African, and one from the Middle East, and we are all in agreement. Which is, I think, a very, very good
Unique
timing now to thank you very much for a very interesting webinar, I believe. Christian, I would like to thank you on behalf of all of us for the opportunity that Quintessence and yourself gave us. And you can have the last words. Thank you, guys, and goodbye.
Thank you, Nitsan. You did a great job, Nitsan.
Thank
You
you,
asked some
Nitsan.
great questions.
Good to see everybody.
The thank you is on our side. I mean, we appreciate that you guys taking the time to share with us a little bit and stay connected in these strange times. We all are eager to be back in the normal settle, to interact, to learn from each other, and we're hoping to give a little bit, opportunities to some people to share some of our knowledge to this channel, which again is at the point the only thing that we can do. So thank you very much, all of you, for taking the time. Thank you, Howie, and thank you, Maurice, for joining last minute. It's always nice to have people like you watching, as well as being in front of the camera. So thanks again. Be well, be safe, and I hope to see each and every one of you very, very soon in real life again. Thank you.
Thank you, Chris.
Bye-bye. Stay safe.
Bye, everybody. Take care.
Nice to see you, Howie.
Take care, all.